Hi, everyone, and welcome to another podcast from the IGCS Radiation Oncology Education Workgroup. I'm Pearly Khaw. I'm the current chair of that work group and a radiation oncologist from Melbourne, Australia. My guest today is Dr. David Gaffney. I'm not sure how many of you know about the lovely Dave, but his bio reads that he is the current Vice Chair and Professor of Radiation Oncology, Senior Director of Clinical Research, and J. Robert and Anne K. Stewart Endowed Professorship at the Huntsman Cancer Institute. His main research interests are in clinical trial development, prognostic markers, radiation sensitizers, and secondary cancers. Welcome, Dave. I will also say Dave and I have known each other for quite some time. So excuse us if we're a little informal today.
Pearly, thank you so much. It's such a pleasure to spend time with you. I'm here in Utah and you're on the other side of the Pacific Ocean. It's really a pleasure. It's been so great to know you for a couple of decades. One of the first things that was posed to me was how did this begin? So I want to share a little bit about myself. So I'm not in the mid portion of my career. I'm closer toward the end. But prior to getting into medicine, I had a lymphoma in my chest and I was treated with chemo and radiotherapy. So that pushed me toward medicine, and I feel very fortunate to have landed in radiation oncology. And then I got involved in gynecologic cancers because I found it was an area where I could contribute. And contributed at that point in the national stage. And to me, that was important. I wanted to be more than a physician. I also wanted to be a researcher and contribute to the research mission. So that's how I got started in all this.
So really it's a personal interest as well for you that drove you to, I guess, segue into radiation oncology, because I noticed that you also have a PhD in biochemistry.
I do. I went through a combined program. We have that in the United States where people can pursue concurrently an MD and a PhD degree. And I was very fortunate to get involved in such a program. And pursuing a PhD made me really want to contribute to the research mission of cancer. I love clinical care. I did 30 years ago and I do today. But I also love the research aspect of our job, and it's been a pleasure to collaborate with people in the United States and around the world in this.
Do you think the PhD kind of laid the groundwork for how you approach clinical research? You've got to learn all those skills, right, to get through your PhD. Did that lay some of the groundwork for how you then went into clinical trials and those skills that you brought to that area?
Well, perhaps, maybe not specifically. I think there's research in the area that, at least in the United States, people who have dual degrees are not higher, don't have more funding than people who have an MD or a PhD. What it did teach me is to be highly critical in my thinking in a scientific sense. And it's not that easy to get a PhD in the United States. And so it also gave me a little bit of toughness. And one of the things that I like in trainees, I like people who finish things. I like finishers. And so that's one of the things that doing a PhD taught me. And it taught me how to write an abstract, how to write a manuscript, how to, think about writing grants. Although my strength is not in grant writing, I dare say.
Oh, I can second that one. PhDs in Australia are pretty tough too, and grant writing seems to come hand in hand with that. And must admit, I don't enjoy grant writing either. But I guess, did that and then getting into radiation oncology also help you develop those skills that ultimately led you towards the collaborative trials groups as well?
Um, Yes, sort of. I have to share that I have worked and lived for nearly the past 35 years in the state of Utah. It's not a populous state. It's a large state. It's probably the size of Germany, but there's only a little over 3 million people. And so there's more, I would say there's more radiation oncologists in a hallway in Houston, Texas, or maybe Melbourne, Australia, than there are in the state of Utah. And so to contribute in a research way, I needed to find like-minded people. So early on, I got involved in RTOG. RTOG stands for Radiation Therapy Oncology Group, and it about 10 years ago morphed into NRG Oncology. And we joined forces with the GOG and with a breast and colorectal group called the NSABP. So that was the beginning of NRG Oncology. And it was a fabulous experience to be involved in that group. I've had the good fortune of being involved in other large organizations, the American Brachytherapy Society, and also the Gynecologic Cancer Intergroup. And that was fascinating, just to see how these groups work, to see how colleagues come together from around the world to discuss clinical trials. Pearly, that's how you and I got to know each other a couple decades ago. And I learned so much from being involved in that, and it was such a pleasure. I also got to be involved in the National Cancer Institute in the US, and to see how they decide which clinical trials to bring forward was also really fascinating. It's quite a competitive environment, and it was really interesting to see all of that play out.
So, where do you see our future with gynae cancers in particular? Is our clinical research future through these collaborative groups, or is there still a role for, I know there are some who think NRG is the be-all and end-all, at least in the States, and I guess NGOT probably has a similar flavour in Europe. It kind of leaves us sitting here in the Asia Pacific region as a little in between. How do we make sure we all come together and keep developing? I know we're all members of GCIG, but are there other ways that we can keep collaborating with each other?
Well, I'm a little bit agnostic about where research comes from. I've had the great fortune of working with a lot of trainees, residents in radiation oncology, and other people. And in a way, I've kind of felt any research is good research, you know. And so I don't care if it's an investigator-initiated trial at your own institution, a cooperative group trial, a pharma trial. We all contribute in meaningful ways. And you ask, where do I see the future? Well, the future is amazing. I mean, it took so long to bring monoclonal antibodies to the clinic, and now we have so many new drugs. Look at endometrial cancer. It's an exceedingly exciting time. There's great challenges how to do this. So as clinicians, how do we mix these different therapies together? And so there's a lot of challenges facing us, but there's tremendous opportunity that I don't think we've had before. And I would encourage young people to get involved in cancer medicine. I think it's a really great time to do that.
So we're not obsolete yet, right?
We are
Radiation
not
oncology is
obsolete.
not obsolete.
No. So we also, I also want to talk about IGCS for a moment. So the International Gynecologic Cancer Society is really pivotal. It's central, and it serves such a global function. It's been so fun to participate in their meetings through the years. They have really great training experience throughout the world. They have an amazing training experience on the surgery side. We are now developing it thanks to Alex Taylor and Nuja Gingran and others on the radiation oncology side, and to help low and middle income countries. They participate in countless echoes. I participate in one on a monthly basis with a a country in Asia with Nepal. It's amazing. It's so interesting. And it's so needed to have a multidisciplinary discussion. IGCS is central to that. And so it's really a pivotal place for us to come together, I think.
Is that what drew you into becoming more involved in IGCS?
Well, I've been fortunate in my career. I've done things that I have enjoyed doing. I want to quote a professor I had in graduate school. We get paid in psychic units. And to me, I've had the liberty of doing the things that I've enjoyed doing. And so I've always enjoyed collaborating with like-minded people that want to promote research. And so that's done in the GCIG. It's done in IGCS. It's such a great opportunity to share information, and I would just encourage us to do that. There are formal ways of doing that, and there are informal ways. A formal way might be presenting a talk at a meeting, but an informal way of presenting our ideas is tumor board or hallway discussions with colleagues, and all of those can be very fruitful and rewarding.
So, how did you get involved first up, I guess, with the IGCS ECHO?
So, well, I guess for me, it was just getting involved, learning more about IGCS. And as I got involved in IGCS and on the board, I realized I needed to understand more about it. I've also had the good fortune of being involved in global research to some extent through the Cervical Cancer Research Network and through GCIG through the years. So I wanted to learn more about echoes, and I was stunned at how interesting it is and how much I enjoy it. There's a good friend that I've known for decades from Melbourne, a radiation oncologist that participates, Professor Narayan, and he and I will periodically argue about things in the tumor conference, but they rely on us, and I get called on almost more than I want to be called on. It's really great, and we have really lively discussions. There's so many young people in my country and in other countries that want to participate in global medicine. This is a fabulous way to do it. So I would highly encourage people to participate in echoes. It's not a big time commitment. It's 1 hour a month. If you miss a session, no big deal. But it's really a good experience.
I'm going to echo that as well, pun intended. I get to have the fun of doing the Fiji Echo once a month, and I must admit the nicest part about that is you have an opportunity to make friends with people in those countries, and to, if you're interested enough, be able to go and spend some time with them too, and I guess learn from them and their experiences, which is what I've probably found most rewarding about getting involved in the ECHO. But Dave, I think you've taken it one step further because you actually nominated to be the RAD-ONC representative on IGCS board. What made you make that step?
Well, I've had great mentors, and a good friend and colleague suggested that I apply, and I hadn't really thought about it. And then I'm like, well, oh, that would be an interesting thing. I've always been very fond of IGCS, and it's been exceedingly rewarding. I'm coming toward the end of my term, and the staff are amazing. The CEO, Mary Eiken's amazing. Our surgical colleagues, medical oncology colleagues on the board are so wonderful to work with. And like I said earlier, it's global, where they care about elevating healthcare for women around the world. And I think it's such a worthwhile goal to try to be involved in that. I would highly encourage our colleagues to get involved. We have been pushing, not hard but gently, to make it more multidisciplinary, to get more radiation oncologists involved. And so I urge my rad onc colleagues to get involved because you're needed. We need to increase awareness of cervix cancer and the other diseases and how we can participate in the care of women with gynecologic cancers.
I guess my own personal view there is I think it's important that we remind people about the importance of radiation oncology, especially in treating cervix cancer, and remember that many developing countries don't necessarily have easy access to us and our skills to treat those women as well. And I guess that's a nice segue into something else I was thinking about. You've been involved in management guidelines and other guidelines throughout your career. And what's your thoughts on those?
Yeah, so I have been involved in guideline development for a long time. There was a wonderful man, a pediatric oncologist, who was at St. Jude's in Tennessee and was pivotal in developing leukemia protocols to cure leukemia in the 70s and 80s. His name was Joe Simone, and he was pivotal in establishing the NCCN guidelines. My initial thought was guidelines are kind of stupid because it will have people not use their heads. They won't. It'll make them not think. They'll just read a line and then proceed and do something accordingly. I don't think that way anymore. I think cancer medicine's got so complicated that it's really pivotal. I don't treat a lot of different sites, and it's a full-time job. I really think it's a hard job to be involved in cancer medicine. I think the guidelines have really elevated the bar. The people that are involved in the development of guidelines, whether they're European guidelines or American guidelines or you name it, are really wonderful, amazing people. And I think they've really elevated the bar. In radiation oncology, we also have contouring guidelines. And it's been really fun to be involved in those. I was involved in the pelvic atlases that were developed nearly 2 decades ago. And despite being a co-author and being in the room when we developed them, I would still put up those guidelines when I would contour a case for years. I just think it's so important that we pay attention to specifically what we're doing. There's a lot of information in that graphic representation in those contouring guidelines. So I really encourage people to pay attention to those contouring guidelines.
Okay, you wrote those very tricky ones. I'm sure I'm speaking for most people here, but I don't know anyone who finds vulva contouring easy.
Well, that was a challenge, and but thankfully we had great people. Patricia Eiffel was involved, and many others, and it was a global effort. They were done quite a while ago, but it was a long process too. So these things aren't straightforward. It takes a lot of collaboration, a lot of input from different people. You did. We talked briefly earlier about what sites I like to treat. In gynecologic cancers, I like to treat really all of them. In cervix cancer, as a radiation oncologist, I feel it's my responsibility. So there's a lot of things to control, and that is the handoff between external beam and brachytherapy to make sure patients complete in the right period of time, to make sure we have the right kind of equipment for the procedures that we do. And it's been really a pleasure. And then I follow those patients pretty closely. Uterine cancer's changed so much. It's been very interesting to be involved, and we have so many new therapies. In vaginal cancer, it's such an interesting disease to treat with interstitial brachytherapy. It's very fascinating. As we talked about, vulvar cancer's hard. It's not easy. They're a constant challenge. And in ovarian cancer, it's a radioresponsive neoplasm, and I think it's underutilized. I think we'll benefit our patients if we get involved in their treatment more often. It's typically not a curative modality, but it can extend time to the next therapy, which I think is really important for our patients.
Chemo-free zone. That's what I like to think of us as.
Yeah.
everyone needs a chemo holiday every now and then, right?
Yeah, that can be very pivotal for patients' quality of life. And so I think we can contribute there.
Do you think, though, even though we've got these contouring guidelines, are we, and management guidelines as well, are we in a place where people are too reliant on them, that if you don't do this, you're doing something wrong? Are we dumbing down, I guess, for want of a better way of explaining it, our own clinical acumen here? Or is it really just
Well,
because the field is so confusing now that we need them?
yeah, that's a great question, and I think something we need to think about a lot. But one of the things our trainees need to understand, which is very difficult to get, is the dose response function for every cancer type that we treat, because that'll aid us in going to the right dose. And that's not that easy to glean to get that information. I do a lot of palliation, and it sort of helps me in contouring because cases are different. And so a guideline is a guideline. It's not a prescription. And so I think whenever you do that, there may be exceptions. You don't want to exactly copy the guideline. You still have to use that thing that's above your shoulders. You got to use your head. So I do think there's a distinct place for guidelines, but there's a place for the clinician. And then I was in a small academic department, and through the years it's grown to be a moderately big academic department. I ask my colleagues questions all the time. I want their feedback, and they give me their feedback, and that's really helpful to me.
I think that comes back to the bits about collaboration, really, isn't it? Because without collaborating with our own colleagues to, I guess, ultimately drive the right outcome for the patient that's sitting in front of us, we can't necessarily collaborate well with our international colleagues because we have to know how to do that right too. Do you think we're getting too insular, or I mean, how do we have to modify our practice? Is it good to have a group practice where we can bounce ideas off each other, rely on each other, or what's your view with regard to that single practitioner type role?
I'm going to go a little strange on you. I'm going to quote a singer-songwriter who passed away from melanoma, Bob Marley. One love. It's one world. This is one world, and it's striking how unified it is in terms of cancer care. So in the radiation oncology echo, there'll be people from 30 different countries, and we're talking the same language, and we understand each other. So it's amazing how the issues are pretty similar in so many different places. I mean, many places may have different capabilities, different machines, etc., but fundamentally the issues that we discuss tend to be the same. And it's been that way through the Gynecologic Cancer Intergroup. It's what we see at the IGCS annual meeting every year. The issues tend to be the same, whether you're in Northern Europe, Australia, the States, or Central Africa.
So have we moved forward in radiation oncology, do you think? Where's our future?
Well, I dare say for the first half of my career, or first maybe even couple decades, I was a bit dysthymic. I was displeased at the pace of cancer care improvement. I don't feel that way anymore. I think everything's gotten better. I think surgery is better. Chemotherapy is markedly better, and radiotherapy is better. Radiotherapy, it hasn't exactly been a renaissance, but the daily imaging that we do, intensity modulated therapy, image guided brachytherapy, all of these things contribute to improved care for the patients. What's the future? Well, we need to continue doing the things we're doing. We need to work together. We need to figure out, what's the optimal way of sequencing these various therapies. We need to advocate for what we feel. We're passionate about the care we deliver, so are the young people that we train. We need to advocate for radiotherapy, and I trust that my colleagues are going to continue to advocate for chemo when they feel like it and surgery when they feel like it, and that's all good.
I guess one of the greatest fears, though, as we look at some of these new trials that are being proposed, is how little involvement radiation oncology have, that some of the louder voices seem to think that we are going to be, I guess, pushed aside in the future. I feel that that's a little premature, if nothing else, given the needs of our counterparts in the developing world. What's your feeling about that sort of?
Well, it's a historic phenomenon. I think there's always been a little fear amongst radiation oncologists. We've been a group that has relied on data, and so we need to encourage each other to acquire information, to publish our results, and let the data speak. And we need to advocate. So if we feel there's a benefit for endometrial cancer patients receiving adjuvant external beam or brachytherapy, we need to state that in our tumor boards, etc. There are certainly cases for de-escalation, but there's certainly places where I strongly believe our patients benefit from radiotherapy, and so we shouldn't be shy. We should state our views boldly and go forward.
I guess this is a nice way just to wrap it up. But what's your feeling about having more radiation oncologists in IGCS?
Well, it's a multidisciplinary society, and I think care is best when you have everybody at the table. We need our surgeons, we need our medical oncologists, we need our radiation oncologists to promote optimal care. Whether you're in Australia or Africa, Europe, or the States, or wherever, we need involvement from everyone. So again, I encourage people to get involved in IGCS. There's so many different ways of getting involved, whether it's being an echo or attending the annual meeting or participating at your own centers in ways that you can. There's lots of ways to grow as a person and an oncologist, and I just encourage everybody to take their own steps in that way.
Thank you very much today for today's interview, and look forward to seeing you at IGCS Cape Town.